Well, hello, hi, I'm Dr. Dounis. I'm a board certified periodontist. I also have done a prosthodontics residency, so I'm dual trained. I think I'm well positioned to discuss about what people are referring to as full arch dental options or as full mouth dental options or as all on X. So typically, the patients that come and see us fall under different categories. Every patient has their own history, their own reasons why they may have lost or losing their teeth. And typically, it comes down to a couple of factors. It comes down to some difficult years where circumstances of life may have gotten in the way, and teeth and mouth has been neglected. As a result, a lot of teeth may have been lost. Some teeth may be causing pain. There has been significant bone loss because when we lose teeth, we also unfortunately lose part of that bone that comes with it. You can see that in a macroscopic scale on elderly folks or not that wear dentures, and when the dentures are removed, the entire facial architecture collapses. And that happens because typically the bone that used to support the teeth is the same bone that supports our lips when we smile and our lower height of the face, meaning the dimension between the nose and the chin. And that typically tends to collapse. So by losing our teeth, our entire facial aspect changes. What goes with that is a significant social impact, a significant psychological impact. People feel more self-conscious. People feel more prone to not smiling, not being as outgoing, avoiding to go out even to eat in restaurants because they feel limited on what they can order from the menu. How can they interact with the person opposite the table? So these are things that we're trying to resolve with dental implants. Dental implants are wonderful replacements for natural teeth. They're never going to be as good as natural teeth. And I'll come back to that point as we move along. So either years of neglect, for whatever reason, genetic predisposition to, say, periodontal disease, treatments, medications, cancer that may have led to dry mouth, which in turn may have led to cavities. A lot of our patients are not aware of the connection between dry mouth and cavities. If one has dry mouth, either because of cancer treatment or because of medications they may be in, they tend to develop a lot of cavities, despite their best efforts. So these are typically the categories of individuals that we see here, and we're trying to restore their smile, their function, and most importantly, their health with full arch dental implant options. In general, we have a couple of different options. We have options that are fixed, which is pretty much what everybody would like. These are bridges. It's a fixed set of teeth that basically screws down on those implants. And we have options that are detachable. That means teeth that doesn't mean they wobble, doesn't mean they're not stable, but the patient has the ability to detach them or remove them, put them on the side, clean whatever is underneath, and put them back on. So two options, fixed and detachable. What decides between the two? Is it finances? Well, a lot of people that come and see us, they feel that if they don't have enough money, they have to have something detachable. That's not the case. This is not how we treatment plan. We treatment plan in a customized approach. In other words, not everybody is the same. This is not a one item in the menu and everybody should conform to that. It doesn't work like that. Each individual, based on their anatomy, availability of bone, smile line, and other multiple factors that we're looking into our planning phase, may be under a different type of proposed plan. And my job really is to be kind of a tour guide. I want to give you a full tour. I want to make sure that patients are fully aware for all their options before they get to decide. Patients need to know what's going to look like that day of surgery, what's going to look like the day after, what's going to look like 5 years later, the commitment when it comes to hygiene and maintenance of those options, and know exactly what to expect before they commit themselves, their families, their time, their finances into this endeavor. So my job is to make sure that I kind of guide you into making the right decision for that. For example, a young individual or a not so young individual that tends to have all their teeth, and the teeth tend to be very compromised. They have cavities, they have holes, they're worn out, and a case that you'll be seeing here may look like this. Well, this individual is probably a very good candidate for teeth that are fixed. In other words, implants will go in exactly where the teeth previously were, and on top of that, a fixed bridge would go on. A second individual who may have lost different sets of teeth in different periods of time, and the bone has become very uneven, may be more compatible with a fixed option again, but this time, unlike the first time where the individual only is missing teeth portion, this individual may also be missing part of the bone. So in an individual like that, we will still be able to provide fixed teeth, but more likely, in an individual like that, we would also have to replace with our fixed bridge part of the gum that has been missing all these years due to the different time frame of teeth being lost. A case like that is presented here. And the details that you can see here is unlike the first case where it's only white. In this case, you also see the pink and you also see the white. And when the patient smiles big, you don't get to see the transition between the natural tissues and the artificial prosthesis. So it looks very, very natural. So both of those groups of individuals get fixed teeth. Now you may say, okay, who gets detachable teeth? Okay, well, let's look at this case together. This is a case where this particular patient has been wearing a denture for about 20 years. And over those 20 years of time, what has occurred is a significant resorption of all that supporting bone that I was referring to before. Now, in an individual like that, when the dentures come out, their entire facial architecture changes. Look at the significant dramatic difference between the patient wearing the denture versus the patient not wearing the denture. It's a significant collapse of that facial architecture. So in an individual like that, if we were to give them fixed set of teeth, it means that a fixed set of teeth will have a significant discrepancy between where the implants are and where the teeth need to be. That whole distance will make things very difficult for the patient to clean. Thus, it's very important that when we give them something to restore the facial profile, to basically make their teeth compatible with their age instead of aging them, that also needs to be something that they can easily remove without acrobatics, clean under, and potentially put it back on. So these are the individuals that get detachable options as a proposed treatment due to cleansability, hygiene, and the need for that prosthetic material to restore the facial architecture that has collapsed over the years with the tremendous bone loss that has occurred. So these are the basically three options: 2 fixed, 1 detachable. There are a lot of subcategories between those options. Some individuals who have a significant medical history and they know how to work with a denture for years because they've had a denture for years, may be benefited even by 2 implants alone. Say on the lower jaw, you can place 2 implants, and instead of having that denture floating everywhere, that denture now can really be way more stable. And since the patient already has been working with a denture for decades, by providing this extra help, this small extra help of 2 additional implants can create a significant positive impact in the quality of life with a very, very simple, very minimally invasive treatment of just placing 2 standalone implants, as you see in this particular case. So a lot of subcategories, and again, every patient is different. There's a lot of marketing when it comes to full arch dental implants, and for those bigger corporations to make this worthwhile, they try to fit everybody under the same option so they can streamline the process and reduce their cost. I'm not interested in that. We were never interested in that here at Synergy. We've been doing that here at Synergy for 10 years. I've been doing it for 20 years. And what we found out is in order to be long-term successful, we need to make sure the treatment plan matches the patient, not the patient matching a significant treatment plan or a specific treatment plan that we have here. So we want to make sure that everybody gets what is best for them long-term. Talking about long-term, what does long-term look like? Because another marketing misconception is that once you get implants, you're done. You don't have to go to the dentist anymore. And you don't have to care for those implants. Nothing happens to them. They're bulletproof, ironclad, whatever you want to call it. That is not the case at all. That is a significant misleading lie, really. So by placing implants, by trying to replace natural dentition, natural tissues with this wonderful option that we have nowadays called dental implants, in fact, the hygiene requirements, the maintenance requirements, or what I call the supportive care requirements, actually increase. In other words, somebody who has a fixed bridge on dental implants and had a history of known periodontal disease, or had a history or is currently still a smoker, or has another systemic factor such as diabetes. These are individuals who are more prone to maybe even losing implants around their teeth. So in those particular higher risk patients, history of gum disease, periodontal disease, history of smoking, history of diabetes, these are the individuals who we need to be able to see them more often for regular hygiene visits. Typically, the protocol is every 3 months. You may hear from commercials or from some of your friends, every 6 months we go to the dentist. Yes, that is for the average individual with full dentition that doesn't face significant challenges or hasn't faced significant challenges with their dentition. For individuals who have lost teeth, for individuals who have lost bone because of disease, obviously that hygiene requirement needs to be more. And in all reality, having a hygiene schedule that is so regimented gives me the ability to be accountable to my patients for those long-term successful options. And in fact, I'm also asking my patients to be accountable to us because we invested all this expertise, all this knowledge, all this wonderful lab work and fantastic results. But for that to work, that can only be achieved with a commitment to long-term health. And in fact, thankfully, those 1-hour appointments every 3 months, which is regular cleaning, the oral cancer screening, X-rays once a year, is not a significant financial commitment or time commitment to be able to enjoy the lasting effects of really restoring one's smile and one's mouth. So that hygiene regimen is really what provides the long-term success. And in others, also we have to identify potentially other factors that may be playing a role on destructive forces. Some people clench, they grind, they tend to destroy teeth, they tend to break some of their teeth because of the excessive forces they're putting on their teeth. Well, these individuals we also want to protect by even identifying those forces ahead of time and providing them some kind of occlusal appliance, a splint, a night guard to protect their restorations and their implants from those destructive forces that unfortunately do not go away once that person loses their teeth. What should the patient expect in a scenario where the dentition is failing? Typically, that would be a procedure that may last from 1 to 2 hours. The patient comes in, they are sedated. We provide moderate conscious sedation IV, and of course, they're completely numb. The teeth come out, the implants go in, and most of the times, the greatest majority of cases, we're able to provide a temporary or a test drive set of fixed teeth that same day. So patient comes in with their teeth in whatever condition they are. They leave here with their dental implants and a set of test drive teeth attached to those implants. Why do we call it a test drive? Because that's what we're doing. We're test driving. You're test driving how well they look. You're test driving how well they fit your smile, how well they work with the opposing dentition, and I am test driving how well you can keep them clean. I'm test driving what's the access look like for hygiene, and a bunch of other options that we have all this time that usually takes from 3 to 4 months, which is the integration period. This is when the implants are taken with the bone, right, before we commit the patient to the final. So patient test drives their temporary teeth, and then we go to the final restoration. Why don't we go to the final ahead of time? Well, number one, we want those implants fully integrated. Number two, there's significant changes in tissues, especially after multiple extractions. Number three, we want to make sure the patient likes the final outcome, not just likes it, but loves the final outcome. So in order to do that, they have the opportunity to have a basis for conversation on their temporary teeth. And they may say, I want those wider, I want them smaller, I want them more white, less white, whatever that may be for the particular individual. They have the opportunity to test drive those, and the loved ones have had the opportunity to comment on those, and they can make a decision on what the final teeth need to look like. So that's pretty much the process in a nutshell. We typically, after the procedure, see the patient about 2 weeks later, and then we see them for a nice hygiene visit, which is a thorough cleaning after all this surgery, make sure that we get them in a good situation. And typically what we ask the patient in those 3 to 4 months of integration is to be very, very careful with the diet. In fact, in our post-operative instructions, we provide a menu or proposed foods that they can eat, because we want the patient, this is not a diet program, right? We want the patient to be well-nourished, but at the same time, we don't want any excessive forces on those test drive teeth. Those test drive teeth look great. The smile is completely restored. People are more confident. They suddenly start smiling wider. But in all reality, from a doctor's standpoint, those test drive teeth are like a cast around a broken arm. And very much like you don't go play basketball with a cast around your arm, that is why we're asking with those test drive teeth to not chew very hard or chewy foods for that period of time. Our staff will guide you during this process. No surprise, you will know exactly what to expect ahead of time. During our consultation, this is something that we spend time on discussing. Now you may say, I already have a dentist and you will be doing all that work. What is the role of my dentist in all this? And really this comes down to a communication from us to your dentist. I have a great many strong relationships with referring doctors, and we have a protocol based on what their comfort level is and what their participation needs to be. And typically the way it works is that we take care of all the foundational work. We take care of all the extractions, implant placement, delivery of the test drive teeth, and once everything checks out, and at the 3 to 4 month mark we have made sure that everything looks good, that's when the dentist typically takes over to finalize that outcome and so on. In all reality, what we're trying to do here is to make it as easy as possible to the patient and to the referring doctors to be able to finish the work. We'd like them involved in the planning. We want to make sure that your doctor is informed, is in agreement, and will be willing to participate in the aftercare of these prostheses. In some cases, we do have individuals who never had that strong relationship with a referring doctor. In those cases, of course, we can customize this protocol accordingly. I hope you enjoyed this very short presentation of the great spectrum of what our practice provides here. We do this routinely. We feel very good about it because we have invested in a significant amount of technology, and we know that we can provide outcomes that are predictable and they work long-term for our patients. Thank you.